This is a modified method that was recently developed by Dr. Guyvaz and Ponsky at Case Western University School of Medicine. The tube consists of a number 16 mushroom or wing catheter with the flared end cut off and then forced into the wide end of a number 16 Medicot cannula with the help of a suture. The silk suture coming out of the cannula is also used to tie to the thread coming out of the patient's mouth. This provides a taper tip catheter assembly system which will come through the gastric and abdominal wall with minimal amount of trauma. This is the flared end of the catheter which was originally cut off, and we are using it as an inner retainer or bumper. Another piece of catheter also has been cut off at the beginning to be used as an outer anchor which will be sutured to the abdominal wall. This patient has been previously prepared with xylocon spray of oral pharynx and intravenous Demerol and Valium. First, a fiber optic gastroscope is passed into his esophagus in the left lateral position. The esophagus is visualized. There is no organic lesion causing obstruction in the esophagus. There is no evidence of esophagitis. The stomach is then entered. At this point, we roll the patient on his back, and the stomach is inflated with room air. A point is selected 2/3 between the umbilicus and mid-left costal margin, as indicated here. The upper abdomen is then prepared in a sterile fashion. The abdominal wall is then transilluminated to ensure the closeness of the gastric with the abdominal wall, and for the point of selection of catheter insertion. The point of entry is anesthetized with the local anesthetics down to the fascia. A 5 mm incision is made with a number 11 scalpel blade through the skin and fascia. A number 16 Medicot catheter is thrust into the stomach via the incision and proper positioning of the catheter is ensured by direct visualization. The needle is then removed and a number 20 silk, a 60-inch silk thread is introduced into the stomach via the catheter. This is then grasped once it reaches the stomach with an alligator forceps. Silk suture and a scope is both removed to the patient's mouth. Previously prepared mushroom catheter is then tied to the silk which is exiting from the patient's mouth. This is lubricated and then it's introduced into the stomach in a retrograde fashion via the mouth, esophagus, and the stomach. The catheter end is then grasped with a grasping forceps and pulled out steadily through the gastric and abdominal wall. The scope is then reintroduced into the stomach in order to ensure proper positioning of the catheter in the stomach. The outer bumper is then slipped over the catheter against the abdominal wall. The position of catheter is fine. Now we take picture of the catheter as it looks inside the stomach. The scope is then removed. After securing the catheter to the abdominal wall, a luer lock adapter is passed through the end of the catheter, so the patient can be started within 24 hours on some supplemental feeding via his gastrostomy.